There is a moment that happens in doctors' offices every single day. You sit there, your arm still slightly tight from the cuff, and your doctor looks at the screen and smiles. 118 over 72, he says. Perfect. And for most people, that would sound like good news. It should feel reassuring. But if you are in your 70s, that number might not be protecting you the way you think. In fact, it could be quietly working against you. I want you to consider something that rarely gets said out loud. The number you've been told to aim for your entire life, that famous 120 over 80, was never really designed for a body like yours today. It didn't come from decades of careful observation in people over 70. It wasn't built around aging arteries or slower physiological responses. It was based largely on studies done in middle-aged adults, people in their 40s and 50s, with flexible blood vessels and faster cardiovascular reflexes. For them, lower pressure meant less strain and fewer heart problems. The logic was sound for that stage of life. But medicine did something that often happens. It took that number and applied it universally, as if the body at 45 and the body at 75 behave the same way. They don't. Before diving in, I'd love to know where you're tuning in from. Leave a comment and feel free to ask questions. And don't forget to subscribe and turn on the bell so you never miss the best health advice from our channel. Together, let's build a healthier, stronger tomorrow. As we age, something very predictable begins to happen inside the body. Your arteries gradually lose their flexibility. They stiffen slowly and quietly, year after year. Imagine a garden hose when it's brand new, soft, responsive, easy to bend. Now compare that to one that's been sitting under the sun for 15 years. It's rigid, less forgiving, and it doesn't handle pressure the same way. That is exactly what happens inside your blood vessels. Because of that stiffness, your heart naturally has to push a little harder to move blood forward, so your resting blood pressure rises slightly. And here's the key point. That increase is not necessarily a disease. It's part of normal aging biology. At the same time, another change is happening, one that most people never hear about. Your body relies on tiny pressure sensors inside your blood vessels called baroreceptors. These sensors are responsible for detecting changes when you move, especially when you go from sitting or lying down to standing up. In younger bodies, they react almost instantly. You stand, they adjust, and blood continues flowing smoothly to your brain without interruption. But after 70, those sensors don't respond as quickly anymore. The reaction is slower, slightly delayed, and that delay becomes important when your baseline blood pressure is already low. Now think about this. If your resting pressure is sitting around 115 or 118 because of medication, there's very little room for error. So when you stand up, gravity pulls blood towards your legs. Your pressure drops for a few seconds. In a younger person, the body corrects it almost immediately. But in an older body with slower reflexes and lower starting pressure, that drop can last longer than it should. And during those extra seconds, your brain is not getting the blood flow it needs. You may not collapse, most people don't. Instead, you feel something subtle, a brief wave of dizziness, a slight dimming around the edges of your vision. Maybe a moment where you feel unsteady, like the ground shifted for just a second. It passes quickly, so quickly that many people dismiss it. They learn to live with it. But let me ask you something honestly. Have you ever stood up and needed to grab something nearby just to steady yourself? A wall, a chair, a door frame? If that has happened to you, even once, your body may already be telling you that your pressure is too low for your current physiology, and this is where things become more serious. In 2019, research published in the Journal of the American Medical Association looked specifically at adults over the age of 75, not younger patients, not theoretical models. Real people, followed over time. What they found challenged everything many of us were taught. The best outcomes in this age group were not seen at 120 systolic. They were seen between 130 and 145. That range was associated with fewer hospitalizations, better cognitive performance, and lower overall mortality, not lower numbers, slightly higher ones. Now, this does not mean that high blood pressure suddenly becomes safe. Levels above 160 or 170 are still dangerous at any age. But there is another side to this equation that often gets ignored. Blood pressure can also be too low for an older body to function safely. And here is the part that truly concerns me. Many people over 70 are being treated aggressively to push their numbers below 120 without ever questioning whether that target is still appropriate for them. Because when pressure drops too low, the risks don't disappear. They change. One of the most alarming findings from that same research was this. Adults over 75 treated to very low targets had a significantly higher risk of serious falls and fractures. And at that age, a fall is not a minor event. It can mean a broken hip, a head injury, weeks in the hospital, and in many cases, the beginning of a rapid decline in independence. There is a difficult irony here. Medications are prescribed to protect the heart and prevent strokes. That intention is absolutely valid. But if those medications lower blood pressure too much, they can increase the risk of a fall, and that fall can lead to exactly the kind of outcome those medications were meant to prevent. What makes this even harder to recognize is where these events happen. Not in the clinic, not under supervision. They happen at home, often early in the morning. You wake up, you stand, your pressure drops before your body has time to adjust, and you lose stability for just a moment. It doesn't get recorded as a blood pressure issue. It gets labeled as a simple fall, an accident, something random. But it isn't random. Inside your body, your brain depends on a constant and uninterrupted supply of blood. Even though it represents only a small percentage of your body weight, it consumes a disproportionately large share of your blood flow every single minute. It cannot tolerate even brief interruptions without consequences, so when your pressure dips, even slightly, and especially if that dip lasts longer than it should, your brain feels it immediately. And here is the part most people never realize. When this happens occasionally, it may seem harmless. But when it happens repeatedly, every morning, every time you stand up, multiple times a day, those small moments begin to accumulate. They are not harmless at all. They are signals that your current blood pressure target may not be aligned with the needs of your body anymore. There is something happening quietly in the background that most people never connect to their blood pressure. It doesn't feel dramatic. It doesn't feel urgent. But over time, it can shape how your brain functions in ways that are easy to overlook at first. Emerging evidence is beginning to show that when the brain is consistently receiving slightly less blood than it needs, not enough to cause a blackout, but enough to reduce optimal function, the effects accumulate. Not in days, not even in weeks, but over months and years. And those effects often get mislabeled. So the next time you hear that your blood pressure looks excellent, I want you to pause and ask a different question. Not just what the numbers say, but how you actually feel. Because numbers don't live your life. You do. Let's make this practical for a moment. I want you to listen carefully and answer honestly, without trying to justify or explain anything away. Have you ever stood up from a chair or gotten out of bed and felt a brief wave of dizziness or lightheadedness? Do your mornings sometimes start with a kind of fatigue that doesn't match the amount of sleep you got? Have you noticed your thinking feels just a little slower than it used to? Words taking longer to come, losing your train of thought mid-sentence, needing an extra second to process something simple? What about your legs? Have they ever felt weak without a clear reason? Or moments where you felt like you might faint, even if you didn't actually lose consciousness? If two or more of those sound familiar, I want you to consider something seriously. Those may not be normal signs of aging. They may be signs that your blood pressure is being pushed too low for your body. I see this pattern more often than I would like. Patients come to me after a cardiac event, and when we go back through their records, everything looks perfect on paper. Blood pressure readings of 116, 114, sometimes even lower. Numbers that would make any textbook look satisfied, and yet when you talk to the patient, you hear a completely different story, months of subtle symptoms, dizziness that was brushed off, fatigue that was blamed on sleep, slower thinking that raised fears of early cognitive decline. There is a term for this, although it rarely gets explained in plain language. It's called iatrogenic hypotension, which simply means the treatment itself is causing the problem. And this is where things become complicated, because those symptoms are easy to misinterpret. Even within the medical system, they are often attributed to aging itself. That's just part of getting older, people are told. But sometimes, and more often than we admit, it's not aging, it's dosage, and you deserve to know the difference, because once you see it clearly, you can do something about it. And the first step is not complicated at all. In fact, it's something you can do at home, today, without any special equipment beyond something you should already have. It's called the orthostatic blood pressure test, and it can reveal more about how your body is truly responding than a single reading taken in a clinic. Here's how it works. Start by lying down flat, either on your bed or on a sofa. Give your body 5 full minutes to settle. No distractions, no phone, no conversation, just rest. Then, without sitting up first, move directly from lying down to standing. Stand the way you normally would when you get up in the morning. Within the first minute of standing, measure your blood pressure. Write down both numbers. Then compare that reading to the one you took while lying down before you stood up. What you are looking for is not just the number itself, but the change between positions. If your systolic pressure, the top number, drops by more than 20 points when you stand, that is called orthostatic hypotension, and that is not something to ignore, because that drop represents a window of vulnerability, a short period of time where your brain is not receiving enough blood, where balance is compromised, and where the risk of a fall increases significantly. If you notice this pattern in your own readings, don't dismiss it. Write it down. Bring those numbers with you to your next appointment. Place them on the table and make sure they are seen. That information matters more than a single perfect reading taken while sitting calmly in an office. Now, let's talk about ranges, because this is where a lot of confusion comes in. For adults between 65 and 74, a systolic pressure between 130 and 140 is generally considered appropriate based on current evidence. Between 75 and 84, that range shifts slightly higher, typically between 135 and 145. And for those 85 and older, or individuals with frailty, reduced muscle mass, a history of falls, or multiple chronic conditions, the range may move higher still, often between 140 and 150. I know that may sound surprising, especially if you've been told for years that anything above 130 is dangerous. But medicine evolves, and the understanding of how blood pressure affects older adults has changed significantly in recent years. This is not about saying your doctor is wrong. Most physicians are applying the guidelines they were trained with, but newer evidence has refined those targets, especially for aging bodies. And there is one more important point to keep in mind. These are general ranges. They are not one size fits all. Your personal target should always take into account your full medical history, including kidney function, diabetes, prior cardiovascular events, and the medications you are currently taking. Which brings us to something that may be even more important than the numbers themselves, the conversation, because most people walk out of their doctor's appointment having said only a fraction of what they actually needed to say. They feel rushed, they don't want to challenge authority, they assume everything is fine because no one told them otherwise. But your health is not a one-way conversation, and in the next part, I'm going to give you 3 specific questions you can bring into your next appointment. Questions that can change how your treatment is managed and help ensure your blood pressure is working for you, not against you. Now let's make this practical, because information without action doesn't change anything. When you walk into your next doctor's appointment, don't go in empty-handed. Go in prepared. Not confrontational, not defensive, just clear and intentional about your health. There are 3 questions I want you to bring with you. And I don't want you to just remember them. I want you to actually write them down. The first one is simple but powerful. Ask, given my age, what is my individualized blood pressure target and what evidence supports that number? Not, is my pressure okay? Not, should I keep doing what I'm doing? Ask for a specific target and the reasoning behind it. A good physician will not feel challenged by that question. They will respect it because it shows you are paying attention. The second question opens an important door. Ask, can we check for orthostatic hypotension right here, lying down, and then standing? This test takes just a few minutes. It's simple, it's safe, and it provides real insight into how your body is functioning outside of that single-seated reading. It's not always done routinely, but when a patient asks for it directly, most doctors will do it without hesitation. And the third question may be the most revealing of all. Ask, could any of the symptoms I've been experiencing, dizziness, fatigue, slower thinking, be related to my blood pressure medication dose? That question changes the direction of the conversation. It gives your doctor permission to consider something that is often overlooked, the possibility that the treatment itself may need adjustment. And let me be very clear about something. Asking these questions does not make you a difficult patient. It makes you an informed one. And informed patients consistently receive better care. I want to come back just for a moment to that number we mentioned earlier, 28%. A 28% higher risk of serious falls and fractures in older adults who are treated too aggressively to lower their blood pressure. That is not a small increase. That is not a statistical detail buried in a paper. That is a meaningful, life-changing difference. Because at 75, 80, or beyond, a fall is not just a fall. It can mean surgery, hospitalization, months of recovery, and sometimes a permanent loss of independence. And what makes this so difficult to accept is that in many cases, that risk is not coming from the disease itself. It's coming from the medication intended to protect you. After more than 30 years in cardiothoracic surgery, this is what continues to surprise me. We focus intensely on perfecting the numbers. We celebrate when that systolic pressure reaches 118. We call it success because it aligns with a guideline. But no one is measuring what happens outside the clinic. No one is watching what happens early in the morning when you stand up in a dim room and your brain doesn't receive enough blood for a few critical seconds. No one is tracking the slow, quiet changes in clarity, in balance, in energy that happen when the brain is consistently receiving just slightly less blood than it needs. So the monitor shows a perfect number, but the patient feels worse. The patient is unsteady, the patient is slowly declining, and everyone is left wondering why. This is the conversation that needs to happen more openly, not just in medical journals, but in real life, in clinics, in pharmacies, at kitchen tables where someone is taking their morning pills and quietly asking themselves why they don't feel as well as they used to. Because if that's you, I want you to hear this clearly. What you've been feeling is not something you just have to accept. It may not be just aging. It may be something that can be adjusted, improved, even reversed. With the right conversation, the right test, and sometimes a small change in medication. And that kind of change doesn't take years. Sometimes it takes a single appointment. Now let's bring everything together so you leave this with a clear plan. The traditional 120/80 target was never designed for bodies in their late 70s or 80s. It was based on younger populations. Applying it universally is not precision medicine, it's habit. Current evidence suggests different ranges depending on age. For those between 65 and 74, a systolic range around 130 to 140 is often appropriate. Between 75 and 84, that shifts to roughly 135 to 145. And beyond 85, or in the presence of frailty, values up to 150 may be more protective than harmful. These are not reckless numbers. They are adaptive ones, aligned with how the body changes over time. We also know that lowering blood pressure too aggressively in older adults increases the risk of serious falls by a significant margin, and those falls are not minor events. They are often life-changing. So if you've been experiencing dizziness when standing, unusual morning fatigue, moments of mental fog, or unexplained weakness, don't dismiss those as inevitable. They may be signals that your current treatment needs to be re-evaluated. And you have a tool available to you right now. The orthostatic blood pressure test, measuring your pressure lying down, then standing, and looking for a drop of more than 20 points. That single piece of information can reveal a hidden risk that a routine office reading might miss entirely. So here's your plan for this week. First, perform the orthostatic test at home. Take your time, write down your numbers carefully. Second, Schedule an appointment with your doctor. Not eventually, not when you get around to it, soon. Bring your results with you. And third, speak up. Ask the questions. Share what you've been feeling. Advocate for your own health. Because the best outcomes don't come from passively accepting a number on a prescription. They come from a partnership between you and your physician. Before we finish, I want to hear from you. Have you ever felt dizzy when standing and assumed it was just part of getting older? Has a change in your medication ever made you feel noticeably better or worse? Leave it in the comments. Your experience might help someone else recognize something they've been ignoring. And if this conversation helped you see your health a little more clearly, share it. Send it to someone you care about over 65. These are the kinds of discussions that don't happen often enough, and they matter. If you want to continue learning about how cardiovascular health changes with age, stay with me. Next week, we're going to talk about cholesterol after 75, another area where the guidelines may not be as clear as we think. And one last thing, everything I've shared here is based on current research and clinical experience, but it is general information. It is not a substitute for personalized medical advice. Your situation is unique and your care should be tailored to you. Use this information as a starting point for a better conversation with your doctor. Take care of yourself. I'll see you in the next one.